I can introduce Dr. Law as the director of the Georgia MemoryNet and associate director of the Alzheimer Center. Those are his titles. But you know what? People are much more than their titles. And what I know about Jim is he's a person who always tries to do the right thing. And that's what's important. That's someone that I want to be here speaking to you, someone who is engaged in the process, who's knowledgeable about the disease and cares and wants to do the right thing. So Jim, come on up here, drop this knowledge on us.
Hello, everybody, and thank you, Antoine, for that nice introduction and doing the background work for me. And it is a pleasure for me to be here. It's they only let me come once a year now because you guys want some variety, and my jokes get stale. But what I'm going to talk to you about is a couple of different things, and one of the things that one of the reasons I'm invited here is because I'm supposed to entertain you, right, as well as educate you. And so one of the things that I want to talk about is cognitive aging. So we talk about disease, and we are going to talk about Alzheimer's disease and disease-related cognitive decline. But I want to talk about just normal aging for a minute, okay? Because there's often a lot of question about, well, what's normal, what's not normal? And there is something called, there are some different ways to think about our cognitive abilities, our intelligence, if you will. It's not necessarily a great term, but there's something that people refer to as fluid intelligence. And what fluid intelligence refers to is your intellectual abilities that are not dependent on prior knowledge. So this is sort of your ability to remember things, process information. One of the reasons why, as we get older, it's harder to teach you old dogs new tricks is because you become a little less flexible over time. And there is a slow decline in fluid intelligence over time with age, okay? And so one of the things that comes with aging is a change in this aspect of our cognitive abilities that parallels our changes in our physical abilities. And so what do I mean by that? So, and this is an example that I've always kind of liked. One of my former mentors, Dr. Linton Hopkins, used to like to talk about elite athletes and their reaction times. So here's an example of what happens as you get older. So this is Atlanta Braves great Chipper Jones lining up to hit a 100-mile-an-hour fastball. Now, a 100-mile-an-hour fastball travels from the pitcher's hand to the mound in about 0.41 seconds. That's its flight time. A major league hitter takes about 0.15 seconds to swing the bat. That means that Chipper Jones has under a quarter of a second to make a decision about whether he's going to swing, whether it's going to be swinging up, down, inside out, outside in. And that's why elite athletes are elite athletes in their 20s and 30s, because that's when our fluid intelligence and our processing in our brains is maximal, most efficient. And I started to make, and I did make, a deep fake of an old Chipper Jones swinging a bat, and I said, oh no, there's too much fake AI stuff out there. I'm not going to do that to Chipper. So I gave ChatGPT a picture of a different guy, a poor man's Shohei Ohtani, and said, show me this guy at age 20 swinging a bat at 100-mile-an-hour fastball. It's not too bad. I look like I'm lining it up. But I said, what's he look like when he's 40 and 60 and 80? Now, there are two things I want to point out about this, or a couple things. One is ChatGPT made me fatter than I was. Two was the 40-year-old me clearly missed that ball. The 60-year-old me, not even close. That 80-year-old me looks frighteningly like my father, and he turned left-handed. So go figure. So this is normal aging, okay? And so that slowing of processing speed, that change in brain function is normal. But it's not all bad news. There is another construct, another thing that we refer to as crystallized intelligence. And this is what is based on your experience and knowledge and education. And so those things actually increase and improve through midlife and then stabilize. You can think of this as your accumulated wisdom of age. So even if your processing speed is slowing down, even if older Chipper Jones wasn't processing and swinging and making decisions just as well, he knew the pitchers better. And so he was able to react and learn from other things. So there is good things that comes with age. And so it's not all downhill. Just remember that. And you still have a lot of positive things with aging. Now, what is the substrate for this? What is the grounds for your intelligence? So this is, I actually think this is a picture of my brain from one of my MRI scans. But the human brain is an amazing organ. There are over 86 billion brain cells, neurons, and then about 100 billion supporting cells, the non-neurons. And each neuron makes connections with 1,000 to 10,000 other neurons. So the numbers start to become astronomical. And this system is dynamic. So your brain is changing with every experience that you have. So you're going to walk out of here, your brain is going to be slightly different, hopefully for the better, but slightly different than it was when you walked in here. And that system is dynamic throughout the lifespan. And then the age-related changes are dependent on your personal experience. And so this is where we get into this notion of lifestyle and experience and what impact that has. So this is something that a lot of us have been using is to discuss this. And this is a report that's released every few years on potentially reversible causes of age-related cognitive impairments, dementia, not normal aging, but abnormal aging. And in early life, one of the most important things that impacts your risk of future cognitive decline is education. So if you have poor access to education, that puts you at higher risk of developing problems when you're older. During midlife, and they changed the definition of this, so this is really during adult life, from 18 to 65, these things, which are potentially reversible and treatable, have significant contributions to your risk of developing abnormal memory decline and dementia in late life. And untreated hearing loss is a really important one. And if you think about it, that makes a lot of sense. If you're not hearing what's going on, you're not interacting with the same richness that you would if you could hear normally and hear conversations and have normal interactions with other people. Things that you would recognize, physical inactivity, diabetes, chronic hypertension and depression, traumatic brain injury, smoking, all of these things, obesity, excessive alcohol, these are things during midlife that can increase your risk of abnormal age-related changes as you get older. And then in late life, social isolation, exposure to air pollution, and vision loss. These are all things that potentially can be modifiable that will reduce your risk of abnormal dementia or cognitive decline. You add all of those things up, and theoretically, 45% of age-related cognitive decline is potentially avoidable. So this is why we say these lifestyle factors related to diet and exercise and activities, education, things like that are so important. And this is the only nerd slide that I left in here, so I took most of these out. So I showed you those fancy pictures of the brain. So when you look at the impact of education over time, what you can see is that people who have higher educational attainment, that's that blue line, have slower loss of volume or shrinkage in certain areas of the brain than people who had lower educational attainment. So you can actually map this out as a physical change that is measurable in the brain that is an impact of your lifetime exposure to education over time. But of course, the thing that we want to know is, well, okay, we talk about these things, and does it really have an impact? We say, do these things, eat right, exercise, do all the correct things, and does that have an impact? And the answer is actually yes. So we all know that the frequency, the number of people who suffer from dementing illnesses, Alzheimer's and related illnesses, is increasing everywhere. And it's increasing primarily because we're living longer. Okay, so if you live longer, I tell you, sorry if this is a stale one you've heard before, but if you want a formula for not getting Alzheimer's disease, I can tell you. You want to know it? You heard this joke before? Number one, be highly selective in your choice of parents. And number two, don't get old. Those are the two biggest risk factors, is age and genetics. But when we look at developed countries around the world, in Scandinavia, in Great Britain, and in the US, and we look at something called age-adjusted incidence or prevalence of dementia. So this means that we're looking over time at people in certain age groups and saying, how many people in this age bucket had dementia? And if we compare, in one of these studies, the frequency of dementia in different age groups, you see 65 going up to over 90, between the years of 1989 and 1995 in this study, and then compare that to the rates of dementia between 2008 and 2011, there is actually a significant reduction, a 30% reduction in age-adjusted rates of dementia over that time period. And the reason for that is public health, education, all of those social factors that we say is going to reduce your risk of dementia have improved with improvements in the economies and in environments around the world, and at least in the developed world. Now, we can also look at this in a specific population, something called the Health and Retirement Study in the United States. And you see the same things pretty much. When you compare the rates of dementia, age-adjusted, from 2000 to 2012, there's a significant reduction from 11.6% to 8.6%. People who have higher education and have greater wealth also have lower risk. So anything to the left side of that dashed line means that there's a significantly lower risk of developing dementia in later life. Unfortunately, that does not apply across the board. And this is one of the reasons why Dr. Parker, Dr. Trammell, and all of us here have really been intent on increasing our understanding of differences in different populations, because if you look at the adjusted rates of dementia among African Americans, it's about twofold higher. If you happen to be black, your risk of developing age-related cognitive impairment is higher than if you're white. Why is that? Well, I told you, you weren't very careful in choosing your parents. That wasn't it. There are a lot of factors. Genetics and aging is huge, but there are a lot of lifestyle factors that we think ultimately going to prove to have enormous influences on our risk. And these are things that we refer to as social determinants of health. And this is what you're exposed to from the time of birth to late life. And that's what kind of access to education do you have, what kind of access to health care, nutrition, environment, exposure to air pollution, to discrimination and stress, all of those things, the risk of hypertension and diabetes, obesity, all of those things that put you at greater risk are impacted by your environment. And so this is something that we really need to think and learn a lot more about as we go forward. And one of the reasons that the health disparities and the lack of proportional and representative sampling that Antoine referred to in the paper is so important, so that we can understand what's driving these differences in risk. And then I'm going to finish up by talking a little bit about some of the advances specific to Alzheimer's disease. So now this is not really specific to any group, but there, as Antoine showed you, there's lots of different reasons why people develop cognitive decline, dementia in late life, and Alzheimer's disease is a major contributor. We're not going to talk about this, but most of people who develop problems don't have just one condition. It actually winds up being a mixture of etiologies, vascular problems, Alzheimer's, and others. But Alzheimer's is something that we've really focused on for a lot of years now. And what you're looking at here are pictures of something called an amyloid PET scan. And the column on the left are a group of individuals who have Alzheimer's disease. And the reds and yellows that you see in that picture are places where they have Alzheimer's amyloid pathology. And then the column on the right is what happens after a year of treatment, either with a placebo, which is that top one that looks just like the one on the left, right? So that person had a placebo, and they didn't have any removal of their Alzheimer's amyloid. But then the three below that are people who had increasing doses of a drug to remove that amyloid and cleared that amyloid out, essentially removed it. And importantly, in this early study, there was evidence that if you did that, there was a dose-dependent slowing of cognitive decline. Not a reversal, not a cure. It doesn't make you a 20-year-old Shohei Ohtani again or anything like that, but it slows down the progression. And that has progressed to a point where we now have 2 drugs that are approved by the FDA for use to slow the progression of Alzheimer's disease in early stage patients. And both of those drugs clear out that amyloid. 70+% of people who are treated with those drugs, after 18 months, you can't find Alzheimer's amyloid in their brains. It's gone. More importantly, the clinical evidence is that if you use these drugs, it slows down the progression of cognitive decline by about 25 to 30%. Now, a very frequent early reaction to that was, big whoop, 25 to 30%. That doesn't sound like a whole hell of a lot. But keep in mind how this is measured. Okay? These studies are done comparing people who got active treatment versus people who got placebo, fake treatment, for that period of time. And that period of time was 18 months. Okay? And so during the time of the treatment where you had either placebo or an active treatment, people who got active treatment declined, but declined 25 to 30% less during that 18-month window than people who are on placebo. Alzheimer's disease is not an 18-month disease. It's a 10, 12, 15-year-long disease. And so if you project that out and say, well, what happens not in 18 months, but in 5 years and 8 years, that difference between people who were untreated and their rate of decline and people who got treated is going to be a whole lot bigger. That difference is going to be a whole lot bigger. And what that means, because most people develop these problems in their 70s and 80s, and you know, ain't not one of us getting out of this damn thing alive, right? The goal is, when you leave, we don't want you to leave out of memory care or skilled nursing. And that's what this gives people a chance to do. So this is the same plot I showed you earlier, what it looks like with normal aging with fluid intelligence. With Alzheimer's disease, it starts to decline and really leads to a lot of functional decline and dementia and dependency. The drugs that we currently have are slowing the progression of Alzheimer's disease. Where we're going, and hopefully within the next 5 to 10 years we'll have evidence of this, where we're going is we're going to not wait until people have early symptoms, but we want to treat them before they even develop symptoms. And then we can reverse it and prevent it altogether so that Alzheimer's and age-related dementia is not even a thing. And that's where we're headed. And so we want you all to participate in that. We all want you to benefit from that. We want to know that the research that we're doing and the things that we think we're discovering are applicable to everybody and not just to subpopulations. Thanks very much. I think we've got questions on timeline for the prevention treatments. So the question was, what's the time? And Antoine or whoever is going to run the show, make sure I don't go out of turn. So there are 2 studies, the same 2 drugs that are currently approved for use in early stage symptoms of Alzheimer's disease. Both of those are being tested in people who have evidence of pathology, but no symptoms. So one thing I didn't cover today is we think that when people develop symptoms of Alzheimer's disease, that pathology has been evolving for 15 to 20 years before they first have memory loss. So that gives us a critical window of time to target that prevention. And both of those drugs are being tested in people in that window. And the one study will read out at the end of 2028, and the other will read out at the end of 2029. So potentially by 2029, 2030, we will have evidence that we can take people, identify who's at risk, and treat them to prevent or delay disease.
Yes, sir.
My question is about the slowing of the progression. You had 2 slides up there that talked about the slowing of the progression. My question is, when the progression slows, how does the disease manifest itself?
So it's a really good question, and I think we're still learning because we're treating these patients right now. We've got about 350 or so patients who've been receiving these treatments. and we're at about, we're past the 18 months of treatment window, and we're seeing how they do. People still decline, okay? And this is, I don't want to overpromise. This is not something that's going to stop the disease in its tracks or reverse it or take somebody from a nursing home and put them back in their house. That ain't going to happen, okay? There appears to be continued decline in memory and other abilities. I don't know that there is a qualitative difference in the changes over time, but it's slower. And so I'm now seeing patients that I've been following for 10 plus years who've been either involved in research trials or active treatment and so on. And normally over the course of 6, 8, 10 years, people are going from very early stages to maybe needing assisted living or memory care. And many of these people are stabilizing enough so that even though their short-term memory is still getting a little bit worse, they're still living at home and taking care of all their basic activities and still interacting by and large normally with people. And so it looks like it's stabilizing and slowing the progression, although I can't tell you whether it's really going to change the way the symptoms manifest over time.
We got a question right here.
If you have a question, just raise your hands and myself or Julius or Jarvis will come to you.
I just, excuse me, I just read an article about how to make it to age 82, and it listed 5 things, but one thing that stood out, and I wonder if this applies to dementia. It said that you should try to learn something new, whether it's a language or some type of skill, and they said by learning something new, it will enhance your brain. So I wonder, would that apply to dementia, trying to, say, for example, learn a language at 65, 75? Will that help your brain and maybe help you against dementia?
Possibly. That pretty picture I showed you of all the brain cells and the connections, and one of the things, there is something called neuroplasticity. And this is a process by which your brain can literally remodel itself. And we think it's all static, but especially when we're young, but even as we get older, there are new brain cells being born and generated. And then beyond that, there are always these 1,000 to 10,000 connections that each brain cell makes with another brain cell. Those things are changing constantly. And so what's going to drive that change? So if you're doing, we got any golfers in here? All right, so when you're playing golf, what are you trying to do? Trying to make the same damn swing every single time. That's why golf is not protective against dementia. But the idea is when you're doing new things, you can think of it like new muscle memory, right? When you're learning new things, you're making different connections, and it's a more dynamic process. So even though that process slows as we get older, continuing to learn new things, continuing to do things that give you a sense of purpose. If you're going to retire, make damn sure you got something you're going to commit yourself to after you retire that's going to keep you engaged and active and thinking about problem solving and learning new things. All of that is true. And I'm not sure why they set 82 as a goal. That's pretty young these days. I'd aim for 92 at least.
We got a
All
question.
right, we have a question over here. Hey, Dr. Law.
Beautiful presentation. Actually, I started going to Dr. Dremel about 2 years ago, and because of my family history of Alzheimer's disease, I became one of his patients in the study. And I've been under medication for the past 2 years, and it has been wonderful. And it's been a game changer for me. And I'm not embarrassed to talk about it because I think there are several people in here who probably need to know about it and talk about it too. So I just want to let you know I'm a living example of what his research and the medication and the caring providers can do for you.
Amen, brother.
We got a question right here.
Dr. Law, thank you for your presentation this morning. How affordable is the new medication? Who prescribes it in your PCP? Does your PCP? Who's qualified? What exams you have to take? Blah, 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 blah.
Yeah, so Those are excellent questions, and I don't want to get too bogged down in the weeds. The drug is available. They are not free of risk. And this is not like stopping by the CVS or Walgreens to pick up a prescription once a month. These are IV infusion drugs given for a period of 18 months. So think of it more like chemotherapy than a routine prescription. Insurance is generally covering it. Anybody have Cigna insurance? Cigna? Cigna sucks. Medicare agrees that this drug is beneficial and is covering it. All other insurance companies for appropriate individuals are covering it. Cigna insists that it remains an experimental therapy and they will not cover it. So, but it is covered. The drugs are, they're not cheap. The annual cost is about $27,000 a year used over 18 months. It's expensive, but we've been thinking about this. Dr. Trammell mentioned Georgia Memory Net. We've been looking at some of our metrics. And when you think about how much it costs to take care of people, both in terms of costs to insurance, Medicare, Medicaid, personal costs, out-of-pocket costs, family costs, caregiving costs per year is a lot. And so if we can keep somebody out of memory care, out of skilled nursing, I think that's going to wind up being a big net gain, a net positive, both financially and personally. It's available. Generally, the people who are prescribing it are neurologists, and many neurologists are kind of shy about doing it because the complexity of doing this. When I look at the numbers, I'm always a little surprised. I think nationally, among the people who are covered by Medicare using their registry, I think the total number of people receiving these drugs is somewhere in the 60,000 range. And we estimate there are probably 1 million people in the country who could potentially benefit. So it's available, it's covered, but managing it is complicated. So we need to make more advances in delivery.
We have a question back here in the back of the room.
Fantastic presentation, both of you. Thank you. My question is, for black men, oftentimes we've got a reputation for just not wanting to be in research. So I want to go back to recruitment and what we talked about earlier, because it seems that you all have been able to be fairly successful with reaching black men where they are. And so I'd like to just know what particular methodology or messaging that you use that may have implications for other researchers who claim they cannot reach black men.
And this is come on, Monica. It's kind of funny. I look at this as a male-female thing partly, as well as a black-white thing. But I think that black men have particularly good reason to be suspicious of the system. Black people in general have reason to be suspicious of the system. And so I think the thing that we've done well is we got in front of you. We tried to have some people, they let me in, but we try to have some people that look like you to try and engender a little bit more confidence and comfort and trust. But, it just takes people to say, I know you. I believe you're not an evil person. I trust you. And I think what you're proposing is reasonable. And men, especially black men, say, okay, I got you. All right. Women, they want us to keep wooing and dining and whining them. Don't do it. And it takes them a lot longer.
So that was really a good question. And there have been some changes in the last year, but it's like, what is, I've been across the country and people are like, well, what's the secret sauce? The secret sauce is you have to have providers and investigators like Dr. Law, who basically took me out of the clinic to get people engaged. And the people I engaged were my patients, some of whom are in this room, some of whom are not, some people in church, people from the sororities, people from the civic organizations that I belong to. I said, this is what they want me to do. How should I go about doing this? And Bishop John Hurst Adams from the AME Church, who was one of my mother's classmates in college, said, Monica, you need to use the formal organizations that exist within the communities. And then the retired school teachers, Jim doesn't like to hear this, but I like retired school teachers, said, well, if you gave us an educational program, and yes, most of them were women, if you gave us an educational program and told us what we needed to know, then we could think about whether we wanted to participate or not. And as a result of that, James Law and Alan Levy pretty much let me design whatever it was you all asked for. When it came to the men, and I'm going to acknowledge them a little bit later, there's a group of men, and I was going to talk to them later, but I'm going to single them out right now. Mr. Karen Graves, David Dorbin, raise your hand, stand up, something. Alvin Griffin, Jarvis Belton, Antoine Trammell, Clinton Dye, Cornelius Flowers. They're your advisory group. So we, every week after this, we sit down and dedupe and figure out what we did right, what we did wrong, what we could do differently. So anything that you see us do is something that has been informed by you. So when it's like, what's the secret sauce? If you pay very close attention, you get to talk to doctors. You don't hear coordinators, you hear doctors. And I'm talking about MD doctors who deal with the subject matter that you are interested in, the PhD doctors who do the bench science that have to do with what's real, and the coordinators are part of the people who implement the research science, and they're all the way around this room. Go on, raise your hands. I'll talk to you all later. But it takes a whole lot of people to get this sort of thing together. And we have a community coalition of those different organizations, whether there are church groups, fraternal groups, professional groups. If you're interested and you really are committed, we talk to you. So our newest community partner is the Andrew and Walter Young YMCA. Shout out to them again, because they are the only satellite program that we are doing for the men's health program. But all of this took a lot of talk, a lot of meetings, and the more you come, the better things are for us, because everybody's a VIP. And if you're a research volunteer and you're a male, I don't care what color you are, you're a super VIP. So if you're not super VIP yet, we need your specimens.
All right, but the question about the men specifically is because Monica is Lynx, she's Alpha Kappa Alpha, she's church ministry. I talked to her for a while, and I only finally got in front of the Omega Sci-Fi brothers last year for the first time. She was too focused on women, and now, but we having this program, and as we go forward, I think what we're going to prove is that this program is the secret sauce specific for black men, being in a place where you are enjoying yourselves, learning things, and fellowship with others that look like you and have your lived experience is, I think, what makes this work really, really well.
Dr. Law, we have a question in the chat from the Andrew and Walter Young YMCA group. They want to know, can a person who is 50 or older start a medication as a precautionary measure, even if their cognitive skills are not declining?
So that's a really good question, and one of the other things that's happened recently is we've developed new tests. So there was a time when really the only test that I could do to prove whether you had that silent Alzheimer's pathology or not was to have a spinal tap. And that was not that big a deal, but that was not something people were pounding down the doors to do. Now you can do it with a blood test, right? And so those of us who have family history of Alzheimer's disease and are terrified of it may go to our primary care doctors and say, Doc, I'm 50, I'm perfectly well, but mom and dad both had Alzheimer's disease, and I want to know if I'm going to get Alzheimer's disease, do this blood test. I'm not recommending that, because right now, if you get a positive test, there is nothing that you can do. There is nothing proven. I said this is going to read out in 2028, 2029, 2030. Once we have something we can do, then there are drugs that are available. Right now, if you're 50, 60, 70, 80, and you don't have any symptoms, there is not a drug that I would recommend that you take, because these drugs have significant side effects. People have died.
All right, we got one right here.
Dr. Law, please come again real soon. Thank you for all the information you shared. Can you just speak to this insulin resistance, diabetic insulin resistance, and cholesterol, and the role it plays in this tragedy?
That's another great, you guys, so, you know, when Antoine was trying to trip you up with what's the difference in Alzheimer's and dementia, are you kidding me? You know what crew you're talking to? They know. But there is, I'm grateful you didn't say, what about this type 3 diabetes? The insulin resistance and the metabolic defects are linked. How they're linked to Alzheimer's and risk of Alzheimer's disease is very complicated. So something called insulin-like growth factor is linked to that same metabolic pathway, and that's a really important pathway that plays a role in the brain and in other tissues with normal aging-related changes. And so we don't really understand exactly why those things change in certain people more than others, but we do know that people who have peripheral metabolic abnormalities like type 2 diabetes, hypercholesterolemia, obesity, other inflammatory conditions are predisposed to worsening problems in those same metabolic areas in the brain. So it's about as you know, there's a lot that we still need to learn, and there are things you may have heard. I think, I'm not sure if this is good or bad, but Novo Nordisk, who has one of those weight loss drugs, I can't remember, Wegovy, I think is theirs, which is? Manjaro. But they just tested their GLP-1 agonist to see if it had an impact on Alzheimer's disease, and they reported out their top-line results. It didn't work. And so there's a lot of thinking about relationships between these metabolic pathways and brain aging, Alzheimer's, and related dementias. But it's complicated, so I don't have an easy answer. It is important that you manage those things. It's critically important that you manage those things related to diabetes and cholesterol to reduce your risks.
We're in the back of the room again here, back here. To your left, Dr. Law.
Good morning, thank you. I wanted to know what will it take to become part of the research study. My father passed, and of course he had dementia. And I have the same symptoms, high blood pressure, and also I have diabetes. But I want to know, is there an age or some type of limit or qualifications to get into the study?
So, the age, generally speaking, people who are under the age of about 50 are too far away. So, you know, because we, so people who are older, so over the age of 50, you can do the Healthy Brain Study. People who are over the age of about 70 or 75, you can do the Alzheimer's Research Center cohort. They're very parallel and similar. There are a few exclusions. So if there are certain conditions that would prevent you from, for example, getting a brain MRI scan or something, you might not be the best candidate for these studies, but we would welcome you in any number of studies. And Dr. Parker is always kind of harsh about this, like, why are you here if you're not going to sign up for research? We want your samples.
That's right.
If you're not going to do it, get out.
Stop eating all the food if you're not going.
We have another question from the Walter and Andrew Young YMCA. Do certain medications that we take on a daily basis have any effect one way or another on dementia risk?
Another great question. So in terms of reducing risk, it's hard to say. There's some evidence that antidepressants, for example, as a class of medications may reduce your risk, but kind of unraveling that from the impact on Alzheimer's or related dementias versus the impact on depression and how depression itself can impact your risk of cognitive decline makes it a little bit harder to say. There are some drugs, and there may be good reasons for taking these drugs, but there's a group of drugs that we refer to as being anticholinergic. So if you think of some of the older allergy medicines that we used to take that gave us dry mouth, or made us drowsy. Benadryl is a good example. We don't like Benadryl. It's an anticholinergic drug. It gives you dry mouth. It makes you sedated. There's some evidence that a long-term exposure to anticholinergic medications may increase your risk. But as a general rule, anything that makes you sleepy, probably not good for you.
All right, right here in the middle, we're going to go 1, 2, and then we're going to come 3 here. Stand up.
Yes, my adopted grandmother passed at 92 from Alzheimer's dementia, and I could deal with the memory loss. The thing that put her in a care facility became very violent. That personality changed. She was a different person. But she became violent. She was a little tiny woman, but very, very violent, and people were afraid. The kids were afraid of her and everything. So in this treatment, what do you do about the extreme behavior that comes of this?
Yeah, so that's a really, really difficult challenge. So there are certain things that land people in care facilities, and one of them is agitation and aggression and violence. We don't have great specific treatments. There are treatments that are being tested all the time, but a lot of what we use are really sort of shaky evidence. So we might use a group of drugs that are known as atypical antipsychotic medications that actually they come with an FDA label warning you about higher risk of stroke and death in dementia patients if you use these drugs. But we use them sometimes because the severity of the problem, when somebody's being aggressive and violent, they're not sleeping, nobody's getting any sleep in the house, we do everything that we can, and so sometimes we use drugs that will literally calm them down. I just said anything that's going to make you sleepy or sedated is not good for you, but sometimes out of necessity we will use some of those drugs either in the home or sometimes in care facilities because the staff are also vulnerable. So that's a really difficult problem. We try to do education and sort of guidance of environmental factors, identifying things that may trigger these behaviors. So certain people may have certain things that trigger aggressive behaviors, or maybe it's flashing them back to something they remember that was an unpleasant experience, or trying to just create a calmer setting around them to try and reduce the rates of that kind of activity happening. But oftentimes there's not a good or easy solution for that problem.
Right here.
Thank you, Doctor, and to you and the team that so graciously blessed us month after month with the knowledge you share. I am saddened and very much disturbed. I was on YouTube listening to Dr. Bobby Price speak about what the medical schools isn't teaching doctors. And Dr. Bobby Price and everyone in this room, feel free to check it out for yourself, mentioned that medical schools is not teaching doctors to check for the toxicity level in the fecal matter of the patients that they're serving. And they're not measuring the amount of toxins, the synthetic products put into our food. I was alarmed that this morning, again on YouTube, they mentioned 12 reasons why you shouldn't shop at Aldi's. And once you look at that for yourselves and see the synthetic poison that's being put into our food matter, it just saddens you.
Yeah,
so my question to you and to the team, and I've asked this question before, is what correlation are you making with holistic medicine so that you're not perceived as just a drug pusher?
So there is a lot of truth, and there is a lot of misinformation, and there is a lot of misinterpretation. There is absolutely no question that there are a lot of toxins in our environment that weren't there before the industrial age. There are a lot of evidence for potential hazards of something called PM 2.5, which is the toxic components of air pollution that can actually get into our bodies, into our brains. There is evidence for detrimental effects of microplastics, pesticides, lots of chemical contaminants in our environment. That said, I'm not sure I know who Dr. Bobby Price is, and I'm not sure what he's advocating I should be checking in fecal matter. There is not a routine test for fecal matter that I'm familiar with that has clear scientific validity in terms of predicting any particular health or illness. And so there is something called the microbiome that we're starting to understand better, and we're studying. And we know that the composition of the bacterial elements that are in our bodies, in our guts, in our skin, in our mouths, that composition of the microbiome can have a significant impact on overall health and wellness. But we don't really understand which particular bacterial species drives that association. And so there is a lot of stuff. I'm a little skeptical of some of the stuff that might appear on YouTube. I think there's a lot of good information on YouTube. Sometimes I'll look for information on YouTube for how to fix something because I'm a lousy handyman, and if I need to figure out how to fix something, I might go to YouTube and find that. But there is also a lot of misinformation and a lot of sensationalism. People can get a lot of attention and a lot of hits by making some outrageous claims. And so I would just be cautious about what you really invest in and what you really take to heart based on what you're seeing on some of what's on YouTube.
Can you hear me? Okay, good. Additional question from the YMCA group. My doctor says Prevagen is a waste of money. Would you agree or suggest any over-the-counter drugs or natural treatments for dementia and Alzheimer's?
This product is not intended to diagnose or treat any medical condition or illness. Is the only truthful statement in the Prevagen ads, because everything else up until that point implies that by doing this you can reverse Alzheimer's disease, and it's just not true. So it is a waste of money. The nutritional information is really important. So supplements. So let me give you an example of omega-3 fatty acids. All right, you guys know what omega-3 fatty acids is, right? And there is actually evidence now that omega-3 fatty acids in pill form may have beneficial effects. But where did that come from? So the whole idea of omega-3 fatty acids and its beneficial effects for heart disease, dementia, and stroke came from some community-based work that was done mostly in Chicago, in one of the neighborhoods in Chicago, where there was a notable low rate of these conditions, Alzheimer's, stroke, heart disease. And there was a high population of Catholics in that area, and they ate fish a lot. So then we said, well, it must be fish, and then they kind of did a little bit more digging. It was cold water fish and fish that had higher omega-3 fatty acid contents, and then next thing you know, we're testing DHA and EPTA and intervention trials, and we're putting them in the pills and marketing it GNC. The evidence is that people who had a diet that was rich in fish that had a healthy dose of omega-3 fatty acids is what led to benefit. We still don't have clear-cut evidence that having these things will reduce the risk of dementia by taking supplements, any supplements. So, I think it's probably not a bad idea for people to take a good general multivitamin with minerals just to make sure there's no deficiencies. But beyond that, I would encourage everybody to do, eat a good heart-healthy diet, lots of plant-based diets, fish, and avoiding a lot of highly processed fats and sugars. And I think that gets you where you want to go in terms of nutrition and things that are going to help promote health. How are we doing on time here, Monica? I don't want to get in trouble.
You're not in trouble.
Okay.
Have you seen any of the data coming out or the reports about creatine and cognition?
I haven't paid a lot of attention to it. There's creatine, and then there's a couple of other phospholipids that appear to be important in both metabolism and also something called membrane remodeling, which is just sort of reorganization of the surface layers of brain cells and other cells. We may find more evidence that specific supplements may be beneficial. We just don't have clear enough evidence to recommend creatine or any other specific supplement to be taken in a proactive manner. Uh-oh.
Did it go out?
There you go.
This will be our last question.
Hello? All right. Thank you. So really good presentation, and thank you all for everything that you do. I had a question, a personal question. I know that Alzheimer's is a cognitive thing we talk about, but are you, depending on if you're left-hand or right-handed, are you differentially impacted? And then I have a program question for Dr. Parker. I live on the South Side, and I've been working all year to get my brother here, who's older than me. I'm about to turn 50, but due to car accidents, I've been aged a little faster, so I'm here. He got 8 kids in work. He can't make it here at this time, Thursdays. How can we work that out? And then also, if you have parents who are older, like a father, he doesn't do anything without my mother. How can we be able to give the female something to do at this time so I can get my dad here?
So I'm gonna let Dr. Parker and Dr. Trammell handle that the hard one. Left-handed, right-handed. Well, you know, you can't help it that you're sinister, right? As far as we know, being left-handed, other than everything being sort of rigged against you, does not increase your risk of Alzheimer's or anything else.
So we have 2 more questions. I'm going to ask a quick one, Dr. Law.
It's okay.
So,
Go ahead.
This gentleman just mentioned something, and I realized my grandmother, as she got older, she started to develop dementia and Alzheimer's, and she was also very mean. I mean, you call on the phone, she'd say some stuff, and you're like, is this really you? However, when she moved out of our house, we put her into a retirement facility, or my uncle put her into a retirement facility, and I feel like once she got into that environment, she forgot that she was mean. So it sounds funny, but how does that regression actually benefit the person when they forget all of the negative things that they used to be?
Well, so, you know, I think this really relates to what I was saying about the environment being the trigger, right? So it's hard to know. It's individual for any particular person, and you know, I think some of you might agree with me when I say that sometimes we're the harshest to those who are closest to us, our spouses, you know, family members. And so there may be certain triggers. The other thing is these facilities have a very structured routine. And so people who have significant cognitive impairment and dementia do not do well. So Chipper Jones could hit curveballs and fastballs, but some people only hit fastballs. And so if you take somebody who's demented and start throwing them curveballs, giving them a chaotic environment with a bunch of grandkids running around, people coming in and out, and they're not going to adjust well to that. And so a very structured routine with predictable activities and cadence to the day will oftentimes make it a lot easier for folks. So sometimes you know, some people have a very negative reaction to being put in a care facility and outside of the normal environment, but other people react just like you described.
You mentioned earlier the study ending in 29 and 30, whether you think you'll have evidence to see whether or not we need to start giving people predictive medicine. My question is about brain health generally, maybe bigger. Are you seeing, does it come across your desk where we're seeing that with other brain diseases, the big ones, schizophrenia or autism or bipolar? Are you beginning to see predictive studies where people are beginning to come out with timetables for successes and measurements?
So I will just confess right up front that this is not my area of expertise. I think that as frightening as Alzheimer's disease has been historically as a diagnosis, it surpassed cancer as the scariest word in the English language for older adults many years ago. But it has had so much focus. I remember when I got into this field in the 90s, it was a desert. When I was looking at residency programs and looking at what area of neurology I was going to go into, nobody wanted to do dementia work because there wasn't a damn thing you could do for them. And we used to think about movement disorders and Parkinson's disease being much better because we could do something about it. Or stroke. I thought about doing interventional stroke because there was something you could do about it. We have now outstripped those other areas, and psychiatry has unfortunately lagged behind in terms of, and it's a lot harder, right? So when we look at Alzheimer's disease, I can see pathologies. I can even see, volume changes and structural changes on MRI scan that show patterns that are reflective of these degenerative brain diseases. You don't see that with bipolar disorder or depression. You don't have a specific pathology that's linked to it. We don't even have markers. So we do something called proteomics in the brain and identify 10,000 different proteins and find patterns that are reflective of Alzheimer's disease. That kind of work has not been done yet in depression and bipolar and some in schizophrenia. Some of it's being done, but a lot of the research is still behind where we are. And so I think that there are a lot of treatments for those conditions in terms of preventions. I have not seen anything. Schizophrenia is a difficult one because it's really a developmental disorder and something that occurs in very young age, and it's probably similar to autism in that it's a developmental process. And so there's not like that window of time that we have with Alzheimer's disease where there's silent pathology that we know is going to progress. This is something that developed from very early age, and so preventing that is going to be difficult. And rewiring that, just like rewiring Alzheimer's disease to turn back the clock, is not something I expect to see in my lifetime. But we have that window, that opportunity to prevent disease, and I don't know that we have that same window in some of these psychiatric conditions, unfortunately. Do you guys want to handle that question about the South Side? Come on now. Come on now. Come on.
What is
Lee and White? Come on.
Wait, what is the South Side? What was the question about the South Side?
The question was, and I appreciate the question. Thank you for the question. And in answer to your question and in response to your question, we are in the Southwest. Southwest YMCA, where are y'all at? They're on screen. Wave at them. They see you. Okay, we have opened up the men's program on the south side of town for the exact same reason that you wanted. We need something over here on this side of town. And all of these things take coordination. We need a dedicated partner, all of that kind of stuff. So over there, our first foray into a dedicated program for that area is being hosted out for the active older adult program at the Southwest YMCA, otherwise known as the Andrew and Walter Young YMCA. So we are there. We're going to be there at least once a quarter on the fourth Thursday. Is that what we agreed to? I think it's the fourth Thursday.
Yes.
The fourth Thursday at the Andrew and Walter Young YMCA. So we're getting there. But I need to also shout out the, I won't say the Sigma Zeta Foundation, but that's what comes to mind. Zeta Phi Beta sorority and the Phi Beta Sigma chapter, Atlanta chapter of the Phi Beta Sigma are hosting the people for this program over at the YMCA. The Sigma Zeta Foundation is one of our community partners as part of our community coalition. If you have an organization and you want to be a part of our coalition, speak to Crystal afterwards, okay? And why is that important? We do have a memorandum of understanding, and honestly, people say they want programs, but it's hard to go into a program. And Dr. Law tells me I'm harsh. Some people like it, some people don't, but I'm from the Northeast, so truth is truth, fact is fact, black is black, white is white. If you show up, we show up. If you don't show up, I can't go there. I can't justify taking a Dr. Law or a Dr. Trammell or any other medical provider out of his or her clinic to see a room of 5 people. That's not going to happen. And I think we can do better. So the fact that you have come here and shown up repeatedly from the men's perspective, we're happy and we appreciate that, and we're going to be your partner. And I know that we call this now the men's program. I want you to know that we're an equal opportunity educator. And if you have friends that may not be of African American descent, maybe they're of Asian descent, maybe they're Native American, but everybody in here is like that, right? Maybe they're Caucasian, okay? But we are appreciative of any men that come to this program, and any of you can come. All of our programs for men are open to all men, not to women. Right. You see us in the room because we're facilitators, right? Ladies, we're facilitators. So that gets me to my part, and stay up here, Jim.
I just want to say, guys, let's give Dr. Law a round of applause for his talk today.
Just so that you know, without a Dr. James Law, none of this would be possible. It's been 15 years coming, like Taylor Swift. I'm a Taylor Swift person. It's been a long time coming.
It's been 17.
17 years? God, that's been a long time. But Dr. Law is probably one of the most socially conscious persons that you're going to want to meet. I wish that all the rest of our colleagues were similarly, looking in that same direction. I was choosing my words carefully because something bad was going to come out. I just say that to say that in these times, we have to be tolerant, and we need to be gracious, and we need to show appreciation for the people that show appreciation to us. So give him another round of applause. I have a Korean son-in-law. He doesn't know that, but I have a Korean son-in-law. And
How very open-minded of you.
I know. I just want you to know we're equal opportunity people. You know, it takes all kinds. And with that, yeah, I do have some people that look like you. All that being said, if you have some friends that may not necessarily be of African descent, bring them. And if you can't come here, you can go to the Southwest YMCA, okay? So we're in the South. And when we have a program for these different churches, when these different groups that say they're going to have an Alzheimer's program and it has Emory Goizueta Alzheimer's Disease Research Center on it, please come. We do programs at Cascade. We've been all over. And if you think we haven't been, we have been. Just because you weren't there didn't mean that we weren't. That's being harsh. Okay. All right. Yes? Okay. Yeah. I don't know why her mic's not on, but our Alzheimer's Disease Research Center has a YouTube. And if you flip over your program, there's something called Brain Talk Live on there. Every Tuesday at 2. Who pays attention? Who's tuning in to Brain Talk Live Tuesdays at 2? Ah, good. Okay, we need you to all sign up and be YouTube subscribers, because anything we do on Tuesday shows up in our archives and is on our YouTube channel. That's evidence-based information delivered by experts from around the country, not just Emory. So we have a lot of people that come, and I do a pretty good job of being harsh and harassing to faculty members to try to get them to be a part of Brain Talk Live so that you get real information from real providers. That's intentional, but that's what you've asked for. So I want you to understand that we make a very conscious effort to reach out, to make sure that we have experts to greet you, and we go where we're wanted. And that's one of the things that I learned in doing this. After everybody said, come, and then people didn't show up, I didn't go back. And I wouldn't ask other people to come and give up their time. I need to move on with the rest of this so that we can get going. So let me get my thank yous out of the way. Thank you, Dr. Law.